Yeah, ready? Good evening, ladies and gentlemen. Thank you for coming out to join us this evening. I'd like to welcome you to this consultation meeting event. A couple of things. We're due to start at 6:30, which by my watch it is, and we're due time to finish at 8:30, and I'll try and keep us to time. My name's Andy Wright, and I'm the independent chair for today. And it's important to state that I am totally independent. I don't work for the NHS. I don't live in the area. I have no particular interest in this, except in this instance to make sure that everybody's opinion is heard fairly. And that means that I will ensure that you have the opportunity to ask your questions as we go through this, but I'll also ensure that the panel has their opportunity to answer as fully as possible. It's a two-way dialogue, and it's important that we keep it going like that. When you're asking questions, I welcome tough questions, but the only thing that I would ask you to do was to respect each other, listen to each other, and allow people to finish before you come back and respond to things. Domestics, before I forget, there is no fire alarm scheduled for today. So if there is a fire alarm, if we do hear the fire alarm, it's genuine. So if you would exit by the clearly marked fire exits to the back of the room and to the sides, and just calmly leave. We're not expected to take roll calls on that point. So anyway, to the matter at hand. We're here today to discuss, incredibly well prepared. We're here today to discuss the future of healthcare in West, North and East Cumbria. There are consultation documents around. I urge you to pick them up if you had the opportunity to read them. And when you leave, there's also the opportunity to take the documents as you need them. The document details all the ways in which you can become involved in a consultation. This event is not the only way that you can be involved in this. The website details all of the other ways that you can get involved. And it's also available as an easy read document in Braille and in other languages if you need to request it. Whilst we're talking about accessibility, we have joining us today a British Sign Language interpreter who will sign and interpret right the way through. I suppose I should ask, is there anybody in the room that requires this service? Okay, thank you. There is also an induction loop, so I suppose we could technically stand the interpreter down. Excellent job that she's doing. But if we do see anybody that needs that, we will reinstate that, okay? There's an induction loop for anybody who has a hearing aid which covers the ground floor. Please use if so. It's also important to note that this evening's proceedings are being audio recorded. So this whole event will form a formal part of the record. So when it comes to the questions, please wait until the microphone reaches you. When the microphone reaches you, I would encourage you, and I've been displaying deliberately poor mic technique as we've been going through this, please keep the microphone close to your mouth so that we can hear that. It's very important because if we don't hear your question and we don't get the responses, all we get is the response, and you may make the most important point or ask the most important question in the entire evening, and it will be lost for the record. So please wait for that. Very important. And I'll also ensure that the panel answer all the questions fully. Okay, so all of that, I'm now going to hand it over to the panel to introduce themselves, which will be followed by a short presentation, and then we will come back for questions and answers. Okay. Well, you're absolutely right. We'll ask the signers to come back. Thank you. Yeah. Yes, please.
Through my interpretation, I did ask if there was any deaf people that needed to see me and wanted an interpreter. I got no responses. That's why I went to the back of the room.
So the interpreter will greet everyone that comes in and find out if they need Okay, thank you. Hope that answers your question. Okay, I'll hand to the panel and ask them to introduce themselves, and then we'll run through a short presentation.
Hi, good evening. I'm Andrew Brittlebank. I'm a doctor, and I'm here this evening because I'm Medical Director of Cumbria Partnership Trust, which is the organisation that provides mental health and community care services for the county.
Good evening, I'm Anna Stabler. I'm the Deputy Director of Nursing Midwifery at the Acute Hospital Trust. I'm a registered nurse and a midwife.
Hello everyone, I'm Stephen Eames. I'm the Chief Executive of the Acute Hospitals Trust.
Good evening everyone, I'm Neil McKay. I lead the success regime, which has been tasked with working together with NHS and other partners within West, North and East Cumbria to produce this consultation document.
Hello everyone, and I'm Dr. Stephen Singleton. I'm the Medical Director of the Success Regime, and it falls to me to start with a brief presentation. I will talk about each slide in case you can't read it at the back or anything. The consultation we're going through at the moment is being led by NHS Cumbria Clinical Commissioning Group. They have the responsibility for leading consultations when particularly the Health Scrutiny Committee of the County Council has said, well, there's a service change proposed here that we need to go through this kind of formal process. However, the CCG is working closely with all the NHS organisations, as represented up here today, and it's everybody working together, which is the success regime. The outcome of the public consultation process is an important factor in the health service decision making. But it's not the only factor, because there's other things, including what the clinical leaders, the doctors and nurses and others think, financial and practical considerations as well. It's important to emphasise at this stage that the consultation happens before decisions get made. Nothing is predetermined. What the timescale for that is, we're listening to what people are saying at the moment, and I'll comment on that as I go through the presentation a little bit. There'll be a period of reflection during January, early February, and the analysis of all the comments that we've had back, including in these meetings, what people respond to the document, what they email in, people writing us letters and so on, will be independently analysed. And then the decision taking will be formally done by the Clinical Commissioning Group on behalf of the whole NHS system sometime in early spring, we hope March time. The public consultation itself, however, is not like a referendum. We're not counting votes, we're not giving one party or another any veto over the plans. What we're doing is discussing options and seeing how people respond to those options. Now, why are we doing anything at all? Why are we changing anything? There are some massive challenges in Cumbria. Overall, for a start, the health of the population isn't as good as we would like it to be. There are things we need to invest in locally in communities to help people make the right decisions and be healthier. And as a community, we need to kind of get behind the idea that we could be better in terms of our health than we are. A massive difficulty for Cumbria is attracting doctors and nurses and other specialists, whether be they pharmacists or physiotherapists and speech therapists and paramedics and so on, where we find it really difficult to get people to apply. So for example, general practice, where I started out my career as a GP in Keswick and then in Kirkbride out on the Solway, and then worked in the Northeast as a medical leader and manager. It was when I was a GP and I advertised for a partner out in a small practice out on the Solway, I had over 100 applications. The situation in the last 15 years is completely reversed to the point where People have been advertising for a year without applications at all. We face that not just in the community and general practice, but in mental health, in the specialist services in the hospital and so on. It's a massive problem. We as a population are also using our hospitals more than in many other places. We're staying there longer when we get admitted to hospital. And whether it's a result of that, whether it's a result of all the agency doctors, we need to cover the vacancies, whether it's a result of past decisions and so on, we're facing a massive financial challenge. And finally, if that were not all bad enough, the CQC, the Care Quality Commission, who comes and inspects our services, has found things to be wanting in all of our providers in some form or another. They find very good things as well. But it's that variation between the good and the bad which is a challenge to us. One of the things that we're facing when we try and attract doctors to come and work in this area is uncertainty overall. So some of these situations are not new, but people say, well, actually, I'm not sure that service is the way I want to work in it, or when are you going to take a decision about how things are going to work in the future? It's bad for our reputation to be in a situation where, to outsiders, it looks like we're not taking key decisions about the future. We need to tackle those difficult issues, some of which have been around for a very long time, and obviously we need your help in making the right decision. Now, the success regime hasn't just been about the few services which are the subject of this consultation. About a year ago, the process was all started and thought through, that got to the point by March, we were publishing a strategy for how we can tackle things like the health problems of the people of Cumbria, how we can sort out the hospitals from a quality point of view, and so on. And we really set that strategy in March around the idea that Cumbria should build on its strength, if you like, what has been a weakness for us in the past, in that we've looked to people outside, like small services struggling to carry on, remote places like here on the West Coast and so on, turn that into a strength and build upon the idea that we can be a place in the UK and even in the world which is just known for its excellence in how we provide integrated care and how we respond to the needs of rural, remote, dispersed communities. Fundamental to that strategy, fundamental to that plan, is making our services work better together in local communities. So that in a place like here in Workington, be it across the Eden Valley, be it in Carlisle, these are different communities with different needs, different populations, different histories, different resources available to them. And yet, we tend to all hear the same stories. I'm prepared to bet that there isn't anybody in the room who either hasn't had the experience themselves or on behalf of their family or something like that, where you're thinking, gosh, I was at the hospital last week and I can't, the district nurse doesn't seem to know that I was in hospital last week. Or you talk to the district nurse and they don't seem to know about the discussion you had with the GP the week before. Or the social worker doesn't seem to understand what's happening to your mum in the ward, in the hospital, and they don't seem to be communicating back with us in the community. And the whole thing just seems to be too full of lots of people trying hard, caring a lot, but it doesn't work for us. The communication doesn't work, we don't get what we need. And by default, what we've seen over the years is people going, blow to all of that, I'm just going to the A&E department, or people not getting the sorts of things that they need. And we know about, our elderly relatives are stranded in hospital sometimes. It's not the right place for them to be, but we can't seem to organise ourselves to get their care back closer to home or in the residential home where they came from. What that leads to, if you spend a long time in hospital, you kind of lose your ability to be back home. So we are a place here in Cumbria which uses residential homes, care homes, much more than you would have thought for the population that we have. So we haven't got people living in their own homes as long as they could. Perhaps because they spent too long in hospital, perhaps because we didn't organise care properly, perhaps because we weren't talking to each other. There's all sorts of possible reasons why we end up like that. But we've got more people sitting in hospital beds than we needed. We've got less care available at home. People aren't able to talk to each other. The IT doesn't always work. There's so much that needs to be organised that fundamentally is the building block of our strategy. That integrated care model, plus the changes we're consulting on at the moment, is how we will get to the position of satisfying the Care Quality Commission that quality is right and safety is right, that we can sustain things, that we've got services which are attracting young doctors and specialist nurses and so on to come into the area. And that ultimately, because we can manage people closer to their homes, in their communities, we're not making as much use of the hospitals as we have done in the past, we can get to a place where we are financially sustainable. So what are the things we're talking about? Children's services. We've got this classic situation I was just talking about of two small services in the hospitals not looking like the sort of service where we can attract young doctors to come and settle here in Cumbria and be part of the process. So we've got these options of changing it. Option one, as you can see there, we've still got inpatients at the Cumberland Infirmary and West Cumberland Hospital. But what we're going to do is change it so that the sicker children are in one place, would be the Cumberland Infirmary, overnight, and we're less dependent on two entirely independent rotas for the consultants and so on. That's our preferred option, but there are two other options in the consultation document that go a bit further. The first one, the second option you can see here, the first of the other two that aren't our preference, you basically get to the stage where it's assessment at the West Cumberland Hospital, but actually the inpatients are all at the Cumberland Infirmary, and then finally the option of full consolidation at the Cumberland Infirmary with only outpatients in West Cumbria. The maternity services, which was the hardest of all, and many of you will know, there's been a process running a couple of years now to try and sort out, again, how to solve this problem of two relatively small services spaced wide apart, real difficulty in recruiting staff, real difficulty with getting the experts to say, yes, that looks right, whether they be the inspectors from the Care Quality Commission, whether it be the maternity specialists at regional and national level and so on. And the three options are well known. This is the one where we've got the most feedback so far. So we absolutely know that communities in the West support the first option of continuing with consultant-led maternity at both the Cumberland Infirmary and West Cumberland Hospital. However, the success regime, noting that that actually is the problem we've been struggling with for years, and it still is going to be a problem sustaining it, the success regime has put a preference on the second option of a midwife-led unit only at West Cumberland Hospital and the higher-risk maternities centralised in the Cumberland Infirmary, where the doctors and the obstetricians and so on would be centralised. And the third option is to consolidate the whole service at the Cumberland Infirmary. Community hospital inpatient beds are another change, which is quite significant. And here, one of the things that we've heard so far, and I just want to emphasise, is that people say, why are you proposing to close these community hospitals when you want this integrated care, when you want care to be delivered locally? Surely a community hospital is a great resource for things like local clinics, so you don't have to travel all the way to Carlisle for an outpatient opinion, or we could put more diagnostic services and develop the community hospital as a hub, as a resource for that place, just as is happening here in Workington? And the answer is, yes, that's exactly what we want, but not all of them in the plans, in the consultation here, will continue to have a relatively small number of beds. So the options there, as you can see, all 4 of them lay out: consolidate the beds and reduce them a little bit at 6 hospital sites, at 5. The impact here in Allerdale falls, and Maryport and Wigton. It also falls over in Eden in terms of Ulston, in terms of where the closures would be with our preferred options, and that's of beds only, I emphasise, not of the hospitals themselves. And this is part of the same strategy that I talked about at the beginning. Firstly, it's about saying we're using the hospitals too much when we ought to be providing care elsewhere. It's partly about the difficulty of recruiting staff, and particularly for nurses who are developing more specialties and so on, looking after a small number of people in a small place just doesn't attract the staff that we want to. So we've had chronic problems of staffing those beds. Emergency and acute care needed to be looked at. It was one that was highlighted by the Care Quality Commission of we really got to think about how these are improved. The options there were firmly the preferred option to say, well, as far as A&E is concerned, we need 24/7 on both sites. There are other options of having urgent care centre and daytime A&E at West Cumberland Hospital, that's number 2, or indeed just a 24/7 urgent care centre at West Cumberland Hospital with a full A&E at Carlisle. But again, the preferred option you can see is to continue 24/7 at West Cumberland Hospital and the Cumberland Infirmary. Now, if any of us forget to say it later, one of the things that's really important in a quick presentation like this is kind of skimming over a whole wide issue. Urgent care is another thing that doesn't work well for people as we would want it to at the moment. It doesn't work well in terms of necessarily getting access to the GP when you fall ill. And there's been some great innovation and development here in Workington on that kind of problem. It doesn't always work well when it's the middle of the night and you're not sure who you're supposed to ring. Am I supposed to ring 111? Do I ring my GP? Should I go to A&E? What am I supposed to do? We've all heard about stories of, ambulance comes and gets you, takes you to hospital, and then waits outside the hospital for a while before you get into A&E. You then wait in A&E much longer than you want, and they can't find you a bed, and you end up on the wrong ward. And, every time I'm in the Cumberland Infirmary, I bump into somebody on one of the corridors, and they're clearly having a conversation about their mum who was admitted last night, and which ward is she on, and what's happened, and so on. It doesn't work well for us. And it isn't just a question of where's the A&E department, it is a question of getting the whole service right, of which stroke is really important. You're probably aware that the way in which we treat heart attack has changed over the last 10 years quite dramatically. And many years ago when I was a GP, sometimes we would manage people with a heart attack in their own homes if they were kind of okay in the first hour or two. Now we have the heart centre, the high-tech stuff, and GPs talk to me about, they see a patient who comes in to see them and they say, well, a couple of days ago I had a heart attack. I went to the Cumberland Infirmary, they put a gadget in my heart, they've given me these medicines and I'm back home already. It's a remarkable transformation. Stroke is going the same way, and I think we need to think of it like a sort of brain attack. Sometimes it's a full stroke, sometimes it's just a warning mini stroke, but we have to deal with it in the same way, and we have to have teams who are really available with the modern. That care in the first week makes a huge difference. And it's the same problem. For years, we've been struggling on with 2 small units, unable to attract all the staff, therefore not working 7 days a week, not available. Speaking as a person who's now old enough to be worrying about this sort of risk, if I had a mini stroke and it was Saturday afternoon, I would want to see a specialist team that day or the next day and be sorted out. I wouldn't want to think, well, actually, I might have to go to A&E and I'll spend ages there, and then they won't know what to do with me, and then maybe they'll send me home, or actually I've recovered, so maybe I'll just go and see my GP on Monday morning, and then the GP would be... I want an emergency service for this kind of thing, and as you can see, the options really are, well, we can try and struggle on. We've got a telemedicine process. We use the technology, so an on-call stroke specialist could be in Wigan or Blackpool talking to us in our own A&E departments at the moment. But actually, it's not just those first few minutes in the A&E department. It is the first week. If we're going to attract the right people and sustain this over the right period of time, we're proposing a dedicated service at the Cumberland Infirmary, and you can see that's our preferred option. What does all of this do? Ultimately, the clinical strategy, the thing we published last March, is the thing that brings us back into financial balance. If we did nothing, we calculated the deficit just gets bigger and bigger, and you can see that figure there, nearly, well, over 160 million if we did nothing. We can't carry on with that kind of overdraft in the system. But if we follow the clinical strategy, if they change the way we work, if we build on these integrated care communities, as we call them, which actually is just common sense in action between the agencies working together locally, if we do all of that, find these new ways of working, we can reverse that trend of overspending and get on top of it. The service changes in this consultation are actually only responsible for a small amount of the saving. And so it's really important to see the service changes as part of responding to the problem of recruiting staff, responding to the safety issues, responding to the 24/7 issues, responding to that kind of thing. And we've got a clinical strategy to solve the money problem. Obviously, this impacts on the West Cumberland Hospital, and you can see that there's a lot of thinking gone on about what's been done so far, and that's part of the consultation as well. It is a couple of years ago, and some of you will remember the review that was done about excess deaths amongst our services. Some changes were done about emergency surgery and trauma, which meant everybody from this part of the world goes to the Cumberland Infirmary. And one of the things people told us at the beginning of this exercise is, we can see why that happens, and we can even see the end result of that, which is good. Fewer people are dying of after emergency surgery, for example. The trauma network, which we share with Newcastle, is helping people who've been badly injured and so on. That's all working. But frankly, if my 11-year-old kid has fallen out of a tree and just broken their wrist, or do they really need to go to the Cumberland Infirmary for hours to sit about in A&E to be told, well, you've broken your wrist, there's not much we can do about that except, put a bit of strapping on it, or maybe you might need a pot or whatever, and then go home again? Couldn't some of this minor trauma and some of the surgery be done locally? And the answer is, now we've shown that the difficult stuff can be done the way we're doing it and saving lives, yes, it should come back. And similarly, the new hospital in West Cumberland is perfectly designed to do planned surgery, safer and better, the individual rooms and so on. So there's more of that planned. And I mentioned this whole thing about where do you go for your diagnosis, and we know, because we can track it, how many people are travelling huge distances to get scans and various other tests. We want to bring more of that back into the West Cumberland Hospital. So ultimately, more people will be treated in West Cumberland than ever before, and the journeys will be for acute things and for maternity, but less for other things. So I've covered the ground I wanted to in terms of presentation, but obviously we're here to listen. We want to hear the questions. And on behalf of the panel, and I've been working with them for a year or so now, we really are listening about why maybe our preferred option is not your preferred option, whether we've thought about everything, how it all adds up together to make a whole, and so on. And that is the point of this evening, for us to have a conversation about what's right and what's wrong in our plans. So thank you very much.
Thank you, Stephen. And thank you to the audience for listening so patiently. It is now time to hand over to you to ask your questions. Now, the way it's going to work tonight is I'm going to ask you to make yourself known. I'm going to take groups of 3 questions and direct them to the panel. I've got a colleague there, Tom, who has a microphone. Please allow him the time to get the microphone to you. When the microphone comes, please ensure that you hold it as close to your mouth as possible so that we get everything recorded. As I said earlier, it may be the most important question or the most important comment that we get tonight, and it's important that it is recorded. I'll take groups of 3. I can't, to help colleagues, we're going to take them spatially together, so I will let you know which way I'm going to go next time. Okay, please be patient. We've got a lot to get through. The other thing that I would ask is that you keep your questions as concise as possible, because the longer you take to ask the question or ask the comment, the less other people have the opportunity to make equally as important points. However, I'm not going to cut you short. You know, just try and make the points as quickly as possible. I'll also ask the panel to be as concise as possible. So, who would like to ask the first question, please? We've got a lady at the front here. 3rd row in. Oh, sorry, I should just mention, because it's recorded, if you want to announce your name and organisation, that's fine, very helpful. But if you want it to remain anonymous and don't, that's equally okay.
I'd like to ask the panel, the transfers that you are planning to take through to Carlisle, has a full risk assessment been done on the outcome of some of these transfers?
Okay. Is there a full risk assessment?
Has a full risk assessment been done on the outcome of any of these transfers?
Brilliant. Thank you very much. Thank you very much for that question. Take another question. Here. Thank you. Just lady at the front.
Right. I just want to ask regarding the maternity services. If you have a lady, a low-risk lady in Whitehaven Hospital, who, well, is in labour and for whatever reason suddenly requires an emergency section, how will it work? If you have, let's say, 15 or 20 minutes to get that lady over to Carlisle, because I assume there won't be any emergency sections in Whitehaven.
Okay. Thank you very much. Emergency sections. Yeah. Okay.
Can I ask another question?
Okay. I'll allow one more question.
All right. If you list here, when you, as you've done it on the screen, when you list all the options in maternity, the option 1 always looks as if it's exactly what we have now, and it isn't, because all high-risk people will go to Carlisle. Why is it not mentioned on the screen? Is that for some distinct reason?
Yeah, so the options aren't fully explored. Yeah, thank you.
Cheers.
One more question. We've got another question, lady.
Regarding strokes, you all say the first hour is vital. It can take an hour. It took 2 to get one to my friend, to get to for an ambulance to arrive. Then it's over an hour to get to Carlisle. What is the guarantee that Carlisle haven't got somebody else in that unit being dealt with? And how quickly can they deal with it? Because they are also short of staff and beds.
Okay, thank you. Question about the risk assessment, question about maternity, and question about this acute. So I'll hand it to the panel and I'll let them identify the best respondent first. We'll take them in order, please.
I might just say we've got some clinical colleagues in the front row who will also be able to help with some of the questions. In terms of the risk assessment question and transfer, Stephen, would you like to have a go at that?
Yeah, of course. We wouldn't be proposing anything where we hadn't done risk assessment. And, you know, the questioner said a full risk assessment. I believe that we have gone through a process which has looked at the risks of all 3 options and other options. It's an ongoing process because people are feeding back to us all of the time further information. The hazards exist for all services. So there are hazards for the existing service, there are hazards for any of the 3 options, and they all have relative risks that we are trying to understand, and we're getting a lot of helpful feedback. So, for example, people are very concerned about the issue, and I'll let my colleagues talk about the maternity issue exactly. People are very concerned about the odd emergencies. Well, we continue to be very concerned about the existing services as well, because of the number of locums, they're covered by paediatricians, and so on and so forth. So the answer is yes. The answer is it's an ongoing process. And the answer is the relative risks are something we need to understand, and that's why we're taking into account what the public are saying to us about their perception of risk. Because my perception of risk, your perception of risk, somebody with a young baby's perception of risk will be different as well. It's very difficult to get to the exact number or the exact sentence that says this is safer than that one. They are, in fact, all different.
Good evening. I'll take your first part of your question first around low-risk women. As a midwife and having worked and set up a midwifery-led unit in another part of the country, when you work in a midwifery-led unit, you work in a very different way to when you're working in a consultant-led unit. It's a very low-risk environment. We don't have all the electronic fetal monitoring equipment. You're using your hands, your eyes and your ears and working with the women and continually risk assessing from when the woman comes in labour. There's very strict and clear guidelines about when you would transfer a woman. And for a caesarean section to be called, you actually have to have a doctor to do that. So you wouldn't have a situation where you would be calling a caesarean section to go into theatre. What I would say is that having worked in a midwifery-led unit, when you are going to transfer women, you tend to transfer them earlier in a pregnancy, and you wouldn't push the labour as you would as if you were on a consultant-led unit. As a midwife working on a consultant-led unit, you know you have a doctor there, so you may not call the doctor in as soon as you would in a midwifery-led unit, and you would transfer them to a consultant-led unit sooner. With regards to the high-risk question that you asked about transferring women, the NICE clinical guidance 190 actually gives clear guidance about the women that should and should not deliver in a midwifery-led unit. And there's a very clear section on place of birth. So the women that would require a consultant-led unit would be risk assessed at the beginning of the pregnancy and would be advised to deliver at the consultant-led unit. The same way, this risk assessment continues right throughout the pregnancy. So if there was an occurrence in the pregnancy that moved them, such as gestational diabetes, we would then be suggesting that they went down to Carlisle.
Can I just add a couple of things? It's worth reminding everyone that our plans include having a dedicated ambulance for the maternity unit as well. And in answer to your question about the slide which suggests there wouldn't be any change with option one, the document makes it pretty clear, I think, that there would be change with option one. We might just need to think about the slide and the way that's written in terms of being clear about that the next time around. In terms of the question about stroke services, Rod Halpin is the medical director for the Acute Trust, and I wonder if Rod might like to help us with that.
Yes, and I see we've been joined by our ambulance service as well. So the point of strokes is it's an example of where systems can come together. First of all, in the recognition of strokes, we know that there's time to be saved there. So training, or at least educating the public to recognize the first symptoms of a developing stroke. Secondly, there is obviously a phase of ambulance response, which in most cases, not all cases, is important. Some people get themselves to hospital. And then the stroke situation is changing very rapidly, a bit like the cardiac, the heart situation, to very much earlier intervention, not only by thrombolysis and recognition, but also in a group of people being rescued by actually removing the clot by invasive techniques, and that is very likely only to be sort of based in very high acuity centres. So it makes the sense to concentrate these expertise in certain areas, and that the people that do this are very rare specialists, so we need to focus it in a small number of very high concentrated centres.
Thank you for that. I'll take the next set of questions. I will return to you in a minute, but I just want to bring some other people into the conversation. Take the gentleman here, the lady there, and then there's a gentleman in the middle over there, and I'll come back to the rest after that.
Thank you. Mr. Stabler, you used the NICE guidelines there on mothers that would go forward for caesarean section. I'm the father of 4 children, all born by various different means. The eldest was born by Cat1 caesarean section. Up until that point, he would have, my wife would have been left in a midwifery-led unit. If it wasn't for fetal monitoring, when we were just before we were about to get sent home to come back the next day, which led to a Cat1 decision, then he wouldn't be with us today. How the guidelines for Cat1 are 30 minutes, decision to delivery. You couldn't get to Carlisle in 30 minutes from decision. With any blue lights or anything, 30 minutes isn't possible. How do you propose to manage cases like that? People, there will be children and possibly mothers lost, without a doubt. Secondly, I have a daughter born by elective caesarean, planned 39 weeks. Your option 2, your preferred option, says that elective caesareans may come back to Whitehaven, but we wouldn't have the special care baby unit. Babies born at 39 weeks have double the rate of respiratory morbidity, and the further back we get from 39 weeks, the higher the increase. Obviously, the risk of going to the full 39 weeks is that a woman with complications might end up in natural labour. Again, the option really isn't there to bring elective caesareans back to Whitehaven at all, is it? Because without that, we're going to lose more mothers and babies.
Thank you for that. Lady here.
I just want to know why you've decided that Carlisle has to be the main hospital and not West Cumberland, because we had a really good hospital, we had really good consultants, paediatricians, we had a really good service. Why does everything have to go to Carlisle?
Hi, I'd like to know, as part of the consultation...
Can you just hold it a bit closer, sorry? As
part of the consultation, the success regime has highlighted its preferred option in every category, yeah? I'd like to know the process that takes place after the consultation, and I'd like to ask what your thinking is, as the likelihood is that every preferred option by yourselves will go through. Because I'm a little bit suspicious, really, that it'll be the preferred option every time. And I'd like to know what transparency is going to be involved in that decision-making process. And I think I'll just slip another question in, really, that you talked about attracting staff to the health service. And, you know, you basically, you're taking the flag down in West Cumbria, and that is not the advertisement that will attract the staff that you so vitally need. Why don't you just improve what you've got? You know, because your initial speech, it really rambled. It talked so much about, you know, things that could be applied to whatever choices you make. Okay. And Nyla, you've got to improve what you've got. Okay. People will die because of the choices you're making, and I want to know how you're going to reach them decisions.
Okay, thank you very much for that. Thank you. Sorry, just a second. Before we start, we've been joined by an extra member of the panel. Just give Matt the opportunity to introduce himself.
Hello there. Apologies, it's a bit late. I did actually get called to an incident, as you can expect, with the ambulance service. My name is Matt House. I'm a consultant paramedic for Cumbria, Lancashire. So I'm the clinical lead for North West Ambulance Service throughout Cumbria, Lancashire.
Thank you.
I seem to have assumed the role of sort of deputy chair, just because the microphone's here. I think, Anna, you might be able to help again with the questions about caesarean sections and risk.
Okay, so as I explained before, if we don't have a consultant in the unit, we can't call a grade 1 category caesarean section. We would be using the dedicated ambulance vehicle following the midwifery risk assessment to take the mother down to the Cumberland Infirmary with a midwife and a paramedic in the ambulance. So I will pass to my ambulance colleague around the transfer time.
I've been looking at the figures just recently, and over the last year, the average time transport between the two is 57 minutes as we currently stand.
But the point that I think is really important and we need to keep re-emphasising is how difficult these issues are in terms of an assessment of risk. There is risk with all aspects of healthcare. It's how you mitigate it and how you manage it. In our opinion, there are greater risks in leaving this service in its present fragile state as it is, notwithstanding the alterations that would need to be made anyway with option 1. So we have to weigh up that against the kind of concerns that you're raising, and quite heartfelt and born out of personal experience. The point that we're making through having a dedicated ambulance, and as Anna's describing, by careful risk assessment by clinical staff in a midwifery-led unit, we are confident, and having looked at the other places who've done similar things, including rural Wales, we are confident that risk can be significantly mitigated. And
sorry,
well,
can we just...
Well, I mean, and the other point that's really worth making as well, we're constantly talking to not just members of the public, but clinical experts as well, who've heavily influenced the way in which our options have been described. Now, someone asked the important question about why Carlisle is the centre of everything, apparently, and not West Cumberland Hospital. I'm going to ask Stephen Singleton if he'd like to answer that.
There's a couple of principal reasons for that. One is the interconnectedness of all the specialties these days, so that when people are, and hospitals increasingly are places where you're very ill. If you're not needing a hospital, you should be, as I said before, being managed closer to your own home. But when you are very ill, when there are things going wrong, the connection between pediatrics, anaesthetics, intensive care, obstetricians, the radiologists, and so on and so forth, tend to make it more and more likely that those specialist teams work together in one place. Now, why Carlisle and not Whitehaven to be that one place? It's because even Carlisle, of course, doesn't stand alone. It's part of a network with Newcastle and with Middlesbrough, in terms of further specialties, like we talked about in stroke. A very small number of people need neurosurgery, which then means they get managed in the stroke unit and then transferred to a neurosurgery unit. A small number of people need thoracic surgery or cardiac surgery, and a small number of very sick children need to go to Newcastle. A small number of pregnant women need to be cared for in Newcastle. So the step from Carlisle to Newcastle, if that progression happens, is also an important reason for beginning to centralise things in Carlisle.
Stephen, would you like to add to that?
Yes, good evening again, everyone. I think it's a really important point that you're making, and it comes up at every meeting that we have. I think it's really important, as the Acute Trust Chief Executive, that I get across as clearly as I can that this is about both hospitals. Yes, there clearly are some changes. It will take some services away from the Whitehaven site, but they're smallish numbers compared to the numbers of patients who will be treating at Whitehaven in the future. Just to put, and it was in the presentation, But my expectation, it's already started, is from 15 months or so from now, there'll be 7,000 more people attending the local hospital in Whitehaven than do today. On the more challenging areas where we've got these high-risk cases, we're talking about hundreds of people, not thousands. So it's really important. And I think the other point I want to make about this is we're spending a lot of money on the Whitehaven site. We're spending 10 million now. And some of that is about creating new facilities for cardiology, for vascular surgery, and for breast care locally, bringing that care back to local people. So I really want to make that point in the context of the history. We intend to change the historical pattern of services, but to do more at the local hospitals in both cases.
Thank you.
I just wanted to add to that. It was the second part of a question that you raised about transparency, and I'm going to ask Peter Rooney in a moment or two, who's the Deputy Chief Executive for the CCG, and it's the CCG, if you remember, who have the legal responsibility for making decisions about these kind of issues, and Peter will tell you about the process in a moment or two. When I started this work with the success regime in September of last year, I was struck by the large number of people who were absolutely convinced that even though the new hospital in Whitehaven hadn't opened, I'd been brought in and we were planning to close it. We would strip all services out of it. We said from the outset that was never going to be the case. We said that it seemed to us change would probably be inevitable. That's what this consultation process is all about. But if you look at the slide that Stephen Singleton referred to earlier, if you add to that the comments that Stephen Eames has mentioned, that there is going to be change, whatever the outcome of consultation, but the hospital in Whitehaven has a fantastic future. It has got wonderful modern facilities. We have to make sure that the accident and emergency department and the emergency service that it supports will remain intact and thrive and develop, and we believe we have a plan for that. We have to make sure that some services that moved en masse in total to Carlisle, as Stephen Singleton said, parts move back. We have to make sure that the residents in this part of West, North and East Cumbria, who are probably referred in large numbers for non-emergency surgery, elective surgery to Carlisle, are given the choice in future so that many of them can have their operations, many of you can have your operations in Whitehaven, whereas at the moment you're referred to Carlisle. Bear in mind the comments that Stephen Eames has made about a £10 million investment happening now. These are really exciting developments. Add to that developments that we're pursuing with the University of Central Lancashire to set up what we call an academic department, a teaching centre, a centre which will also specialise in research, and the appointment of 2 professors very recently, and we hope and we expect new appointments to join those professors. Those kinds of things will contribute to make West Cumberland Hospital a vibrant institution for the future, at the centre of this vision that we describe, where we foresee real potential for West, North and East Cumbria to become an international centre of excellence for services for people nearer to their homes. So, far from your point about running up the white flag for West Cumberland Hospital, we do understand why people are concerned about the potential loss of services. But please also bear in mind the huge effort that's going into trying to make sure more and more services in overall terms go into the new West Cumberland Hospital. Now, your other point, which is very important also, which is the question of what happens after consultation. How can you be assured that there'll be transparency? Peter Rooney, the Deputy Chief Executive of the CCG, is the man who's best placed to answer that.
Good evening, everyone. Can you hear me okay? Yeah? I think it was your question, is that right? Yes. So I think the question in 2 different bits. The first was, what will be the process by which we will make our decision? And I think secondly, you had some understandable caution about will we simply go ahead with all of our preferred options. So those are the 2 bits I'm going to try and address. So the consultation runs until the 19th of December. I would want to encourage everybody in the room, and indeed everybody who lives in this part of the world, to make a response on any of the issues of the consultation that they are interested in. We are desperately keen to hear your views. In terms of what happens after the 19th of December, the first thing is that an independent organisation will compile a report and an analysis of all of the feedback that we have received so that we have a good understanding of all of the issues that members of the community, stakeholder groups and local clinicians have raised. Once we have that document, we will have a further process of local clinicians, so people who work in our services now, with some support from external clinicians where they have a particular recognised expertise in the issue that we're considering, to consider all of the feedback and to make their best recommendations on what they believe is the best way to deliver services in this part of the county. In terms of the decision making, we will make a decision based on 4 equally weighted criteria. So the 4 criteria are, firstly, the impact that we believe the service change would have on the health and well-being of the overall population, including health inequalities. And I think, as some of the panel members have already described, we have very significant differences in health outcomes, basically depending on where you live. So that's the first area. The second area is the impact on the quality of care delivered, and that's split 3 ways, really. So one is on clinical safety, one is on clinical outcome, and the third area is on patient experience. The third criteria is the impact on efficiency, which does partly mean money. So it is a fact of life that we do have to secure the best possible services within the resources that we have available. So that will be one of the 4 equally weighted criteria. The fourth and final criteria is simply about deliverability. Can the option be done? And so one of the really important factors that you've kind of already heard described a little bit today is about, will we have the workforce to deliver the option? Will our, in terms of hospital changes, will our physical buildings accommodate the change? Those kind of practical considerations. So there will be the 4 options. That will all be made in terms of recommendation to my organisation, the Clinical Commissioning Group. Our governing body will meet. The governing body includes representatives of local general practitioners. And we will come to a conclusion, but we will come to a conclusion informed by the views of each of the partner organisations, including those which are represented upon the stage. So we will seek input from North West Ambulance Service, from North Cumbria University Hospital Trust, and from Cumbria Partnership Trust. So that's the process. In terms of the preferred options, and will they all just be taken forward, and in some sense, wouldn't that be a surprise? I think was the nature of your observation. I guess the things I would want to say there is that lots of colleagues agonised, and I think it's the right word actually, understandably, over arriving at what we thought were the preferred options at that point in time, based on the information that we had available. So the colleagues on the stand and other colleagues believed that was the right thing to do based on the information we had at that time. We are consulting because we genuinely believe members of the public and clinicians and so on may have improvements to those options and may have better ideas. And we would be reckless and foolish not to pay good attention to that. So when people say no decision has been made, no decision has been made. But it would have been wrong of us to have had a view about the preferred option at that point in time and not been clear with everyone what that was. Hopefully I've addressed your question. I suspect I've taken too much time. Thank you.
Thank you. Okay, unless the panel has anything to add to that, I'm going to take 3 more questions. So I've got a gentleman who's been waiting very patiently there.
I respectfully disagree with Sir Neil about the present services which is unsafe. I think it is very safe service which has been provided at West Cumberland Hospital for the last 25 years. It is fully staffed, including consultant and the middle grade doctors. The recent appointment has not been publicized in the news media, and I think that should be the important thing to do, because there is an appointment has been made at West Cumberland Hospital. Second thing I would like to say is the West Wales. The West Wales has been mentioned as a comparison. The area which the success regime is comparing West Cumbria to West Wales is the population density of that area is 25 people per square kilometers, compared to West Cumbria has 97 people per square kilometers. And I also think that the maximum number of the delivery per year is 160, while in West Cumbria we will have in excess of 500. So it is absolutely disgenuine comparison, and it is not acceptable that we have been compared with the area which is also uses the helicopter to transfer the pregnant woman. Okay. And the lastly I would like to make is there is absolutely no evidence that beyond the 45 minutes of the traveling time is safe. In fact, there is an evidence that beyond the traveling time of 45 minutes is genuinely unsafe. And there are more babies will suffer and a mother will suffer. And I think the success regime will be well advised to look at the area which is nothing like West Cumbria in West Wales.
Thank you. Okay, can I have the lady at the back there? I will return to you, gentleman at the front.
Hello. I work at Carlisle, so I travel every day from Workington, and I was late for work 3 times last week because I was stuck behind slow-moving vehicles. So it's just a point. You were talking about NICE guidelines before. NICE guidelines are evidence-based. I work in the research department. They're evidence-based. We do the research. We find out what's safest, what's best, what works for patients. If you're saying that you work to NICE guidelines, how can you say that you're not using electronic monitoring, you're not using fetal monitoring in your midwife-led department when it's proven to work? You're saying that you're just using, and no disrespect, I'm sure the midwives are great at their jobs, but if that technology's there, you're not using it, and just because you're not using it doesn't mean that things that monitors aren't happening, and that's frightening for ladies. You can't say that you're not going to use technology that works, that's proven to work. NHS care is supposed to be evidence-based.
Okay, so the point is that you're saying that there's evidence-based and the technology works.
And I'd like to know why you're suggesting that we should run a department not using that.
Okay, thank you very much. Thank you for the question. I'll take another question from the gentleman on the end there. Thank you.
Hi, my name's Peter McGuckin. I'm a local businessman. I also travel to Carlisle quite a lot with work during the day, and you know in the summer months that you're always going to be stuck behind a tractor both ways, which I know you're a very good driver being with an ambulance, but for people like me who might have my pregnant wife in with me screaming her head off because she's in labour, I might take more risks to go around that tractor, and that would cause some possible traffic accidents on a really bad road. So that's one risk assessment that needs to be looked at, I would have thought. Also, just going off some of your own comments, you said about bringing services back to West Cumbria. Why would you go to Carlisle and when it takes a long time to get there because of the distances, when your son might have broke his arm or daughter, when you could go to West Cumberland? You want to bring services back where people have the time to travel to Carlisle in their own cars. It's minor things, but you want to take the resources away when people desperately need it within minutes.
So you're asking about the prioritisation?
Yeah, it's a case of you bringing services back that people can go to Carlisle for. I mean, you know, when she grows up, if she falls and breaks her arm, I'm much happier taking her to Carlisle to get treated. I'm happy to wait, a couple extra half hour, whereas we were low risk until 20 minutes before the baby was born and she had to be delivered by, episiotomy. Now, would that be done in a midwife unit? There's not enough information out there to say what actually does, what is a midwife unit do?
So there's the travelling distance, and there's also the issue about the
Well, just there's a paragraph there to say that it might be a midwife-led unit, but I bet most people in this room don't know what happens in a midwife-led unit. So
So
should
we'll
that not go out as a document so we can make an informed decision?
Fantastic, thank you. Sorry, well, I will return to you. Thank you.
I just wanted to start the response to Mahesh's challenge. I haven't said that services are unsafe at West Cumberland Hospital. The CQC, the regulator, the Care Quality Commission, have expressed concerns that some services are what they call inadequate. That's not to say they're unsafe, but it means that if something doesn't happen to make them better, then they might become unsafe. And the premise in our consultation document is that change needs to happen. Whatever the outcome of consultation, some change is absolutely essential. And if it doesn't happen, then our worry is that services run a higher risk of becoming unsafe, but they're not unsafe now, and I think that's a really important point. You raised questions about appointments and vacancies being filled. I'm going to hand over to Stephen Eames to deal with that question, and we have a paediatrician in the audience because this has been one of the toughest areas of recruitment that the Trust has faced, and he might like to say something about this as well.
Yes, thank you. Mahesh, as ever, you asked some very important questions. In the context of the appointment, I'm not sure what the specific appointment is that you're talking about. So perhaps we could clarify that. But I can make it absolutely clear that if you're talking about paediatricians, are you talking about a different specialty? Let me deal with obstetrics first. So we have recently, under my guidance and support and investment within the Trust, appointed some middle grade doctors on fixed term contracts to support our maternity service, which is a great thing because that means we're not dependent on shorter term locums. That's not, though, a long term sustainable position. That's the first point. We have appointed one new paediatrician to the Trust, and that's against the backdrop of a vacancy factor of, I think I'm right in saying, 5 currently down in West Cumberland. That appointment actually has been made to Carlisle with a link to Newcastle based on our recent established partnership with Newcastle. So that's the only other appointment in paediatrics. And could I just make your last point was about I think the Welsh experience and so on. There's a team of people from across the Trust and other parts of the local system going to Wales tomorrow, and we'll feed back those comments because clearly it'll be very useful to explore the points you make in that in the context of that visit, which we'll be able to feed back on. But I would add the point that I think was made a little earlier by Stephen in the presentation. There has been 2 years' worth of work around these very challenging issues around maternity and transport. So Wales is one area, but I know the team have looked at Scotland, the Southwest, international examples. And all of these places have their own unique flavour, but they're all meeting the same sorts of challenges. So I would gently challenge back that you can compare West Cumbria to other parts of this country and in the rest of Europe.
Thank you. Could we return to the question around evidence-based as well, please?
Yeah, Anna?
Yeah. Baroness Cumberledge has done a huge piece of work this year looking at maternity services up and down the country, and the result of that work is that she is promoting normal birth within midwifery-led units and at home. Now, when you deliver in a midwifery-led unit, it's seen as an alternative to delivering at home in your own bed. All the evidence shows those women who deliver, who have been identified as low risk, who choose to deliver in a midwifery-led unit, are more likely to have a successful delivery than a low-risk woman delivering in a consultant-led unit. In a midwifery-led unit, you use your midwifery skills. And as a midwife, when you are trained to use your hands, your ears, and talking to the women. So you've got your electronic sonic aid that you listen to the fetal heart, but you do not use an electronic fetal monitoring machine. You use the sonic aid, and you would be able to do all manner of things as a midwife, such as, and I'll pick up on the lady's question behind you, you said you needed an episiotomy to have your babies delivered. That would most certainly happen within a midwifery-led unit, and the midwives are trained to stitch you back up again, so you wouldn't need to go anywhere afterwards. As midwives, we are highly skilled practitioners. We train intensively around situations and have skills drills all the time to make sure that we can provide safe care for women. And we would continue to do those skills drills within a midwifery-led unit and our consultant-led unit. And should option 1 be the preferred option, I'm sure we would be undertaking skills drills with our partners, NWAS.
Just a couple of things. I thought your suggestion about producing something on our website that describes a midwifery-led unit in more detail is a very good one. We give some information, but it's not as graphic as Anna has been describing, and we'll certainly do something about that. I have a feeling, was there another question about access and transport?
Yeah, the question was about where the location of the services and the immediate demand for maternity services opposed to acute injury services.
Well, I mean, in one sense, we've answered that as best we can so far. Don't forget that there's going to be a dedicated ambulance that NWAS will provide. Don't forget the comments that Anna's made about the assessment of risk. And
sorry, we will come back to you. Wait a minute, please.
Well, the protocol will be that there will be the next priority will be a response from the NWAS for maternity service. That's the kind of protocol in outline that we've agreed so far. So we are looking more and more at that kind of very slim possibility. It might arise, you're right, and we've got to have a response for that.
Could I just add something here? I think it's very important to make this point. I know we're talking about maternity, but if you look at the totality of hospital-based care that we provide every day, we're experts in transfers between our hospitals. And by that I mean, but let me finish the point. We're experts. By that I mean the clinical staff on the ground constantly assessing risk in every specialty, and in doing so, they're following protocols that are both nationally and locally designed. Some of those locally designed protocols specifically relate to the challenges of travel in this part of the world. And one of the things that I always say in these meetings, and it may well be something else we might want to add to the information on the website, is we've looked at those transfers with the ambulance service over the past 4 years, and there have been no serious incidents. The care has been good quality all the way through. So my point is, there is a challenge about transport and access, but we've got very experienced clinical practitioners in the hospital, on the roads, who are dealing with this every day of their working lives.
Can I just also add that we are already transferring women when they're in labour. We will transfer women as far as Middlesbrough and Newcastle already with the ambulance service, with a midwife, to make sure that they are delivered in the most appropriate unit if their pregnancy is premature. Or we would deliver them, and then the flying squad could come and retrieve the baby and mum and transfer out. So these transfers are actually happening now and happening safely.
Thank you. Right, okay, I'll take another set of questions. I will get back to you in just a minute. We'll take that lady there, please.
My question is, are there enough ambulances to deal with all the transfers that will happen? And can we be assured that they will be available when they're needed? Bearing in mind it takes on average 57 minutes to transfer to Carlisle. If something happens and an ambulance is delayed, for example, will that impact on the next emergency that possibly needs transferred?
Okay, thank you. This gentleman's been waiting very patiently down here, so I'll take a question and I'll go over there.
Yeah, my question was about risk assessment, because you basically said, oh, you can't really quantify the risk. However, I actually do have a document in front of me now, which is a risk matrix of risk managers in the NHS. And upon the matrix itself, it basically says there's a catastrophic risk would be incident leading to death, multiple injuries, or irreversible health effects. So you're looking there against the severity and also against the actual probability, monthly, say, given the number of transfers, that would be possible.
So can I just clarify, are you looking at something that's specifically related to this consultation?
I'm looking at a generic risk risk
so
matrix.
General, just
now,
for clarity.
So that would put the risk as high or extreme.
Yeah.
Now, I've worked in risk assessment for 15 years. If I had a risk that came as high or extreme, I would not be exploring that option. What response would they have to that?
Okay, thank you. Thank you. And we had one question. That lady there, please.
Hiya. You're saying about all these midwives that are going to be delivering in the midwife-led unit. Are you not concerned that you're going to actually lose midwives and members of staff because the responsibility and the pressure on them is going to be too great? They're going to be frightened that they're going to lose women, even though they are capable of doing their job. The pressure you're actually putting on them, that our lives and babies' lives are in their hands, you're actually going to lose. You're going to lose these members of staff that you're relying on for this midwife-led unit, and then what are you going to do?
Thank you. Thank you very much for those questions. I'd like to ask Stephen to respond to the risk question, and it was very important to just clarify that that was a national risk assessment matrix.
Yeah, I think you've obviously got a lot of experience in the field, as you said. That is, I think what you're talking about is the national policy guidance to the NHS about how you assess and manage risk, judging by your description. And we use that every day, all the time. Anything that's regarded as a catastrophic risk effectively means you have to close the service, by definition. And as has been said earlier on the panel, we're very confident, and I'm very confident, as I probably practiced it as long as you, but maybe not all the time as much as you. None of us would really recommend any options that led to catastrophic consequences. I think we're talking about, which again I think you would probably appreciate from your experience, the balance of risk between these differing, challenging scenarios, and it's a tough question, you're absolutely right, but I guess we have to try and make some assessments, and that's why the sort of feedback you're giving us and others are giving us is so important in the final analysis, as Peter was saying. Well, we've done a lot of it, but we would do more of it on the back of all of the feedback, as Peter was saying, when we get to that point.
With regards to the midwives, I hear what you're saying, but I see this as a huge opportunity. As a midwife, it's about having the experience and the skills to practice being with women, which is what midwife means. We already do support our midwives to train in things like episiotomies, cannulation, suturing, neonatal resuscitation. We will provide more training if that's what they require to make them feel confident to deliver this service. You know, we already have been expanding our nursing staff around being advanced nurse practitioners. We are already looking at developing advanced midwifery practitioners to support those midwives working in those units, should this be the preferred option. As a midwife myself, I would find that a really exciting opportunity. Being able to work autonomously, which midwives like to do, without having to answer anybody, but doing it safely with the requisite skills.
And then we just leave the question about transfers.
There was a question about ambulance service capacity, I think.
In terms of ambulance capacity, I think like the rest of the NHS, particularly in West Cumbria, we've struggled with staffing up until very recently. We've had a big push on staffing the last 6 months or so, and we're in a position now where come April, all things being equal, we will have full staffing in West Cumbria, in fact North, West and East Cumbria, which is the first time we've been in that position for some time. That doesn't include any specific transfer vehicles. So at the moment we're looking at one dedicated transfer vehicle for the maternity that we've already spoken about. And obviously we're continually talking about any transfer of services between the two sites and whether that would involve more ambulances. So that will be, the discussions on that will continue. But as we stand, we have, we're looking at April to have full staffing. And then, obviously, we would look over and above that for any specific transfer vehicles.
Thank you. Right. Next set of questions, please. I'm going to go to the back because we've had none from there. So there's one there's a lady right at the back there.
Hello. Low-risk ladies can be admitted to midwifery-led unit, or even what we've got at the moment at West. I'm actually a midwife there, and things can go wrong very, very quickly. And again, you haven't got 57 minutes to get to Carlisle. So how do you anticipate we're going to solve that problem?
Okay.
As a midwife, I would absolutely love to work in a midwifery-led unit, but not 40 miles away from a consultant-led unit. And I just don't know how we're going to get these ladies transferred. You know, we do all have skills, very advanced skills, but if we're listening with the handheld drop tone, we can still hear if a baby's heartbeat is dropping. What are we going to do in that situation?
Okay, so the question is about critical responses. Thank you. There's a lady standing by there, just right by you.
There's a lot of talk here about cutting back these services or changing them, and it seems that there's a lot of reliance on services closer to home, integrated communities. I work out in the community as a health visitor, and I don't know what resources are out there to make this system work. There's cutbacks out in the community, in children's services, in all services. Where is the resources going to come to make effective preventative care that's going to allow this to work? Because it feels that there's just going to be cuts in all directions.
Okay, thank you very much. Gentleman was making himself aware there. Can you? Yeah, there.
My name's David Morgan. I'm a retired paramedic, 40 years on the service, I know that well. I've travelled that road hundreds of times, and it's a complete nightmare. I think Mr. Eames should get himself on a stretcher and ambulance at West Cumberland Hospital and blue light it through the car and see what he thinks about it. And as far as this dedicated ambulance goes at West Cumberland, I know how the system works. That ambulance is going to be used all over the place. It's hardly going to be available. Plus, when ambulances get through to Carlisle, I've been talking to my ex-colleagues, they're being used in Carlisle and they're not getting back here. They're being used for jobs in Carlisle, so it's a big problem, and it's unfair.
So it's about resource allocation. Thank you very much for that question.
There's several times I've been going through to Carlisle over the years, and for one reason or another, the road's blocked. We've had to cut across to Workington and go on the A596.
Okay, thank you very much.
That's another problem. That's a worse road to travel as well.
Thank you.
I wonder if we might start with the question that the lady at the back, health visitor, raised. We've got in the audience Neil McGreevy, who is a local GP and who's helping us think about how to develop and implement this concept of integrated care communities. Neil, would you like to just say something about that, which we've not had a chance to explain other than in Stephen's presentation, and it's such an important part of our overall plan for the future.
Okay, evening everyone. Integrated care communities. Sorry, before I even start, can I declare an interest? As many of you know, I've been GP in town for a long, long time, but I've also done some work for the CCG in recent years. So I think it's important to mention that. I think not my main interest, but one of my big interests in the success regime is the fact that it recognises that we need to do more in our communities. For far too long, we have been sending people to hospital that really don't need it. I mean children, I mean adults, I mean elderly. Across the board, far too many people end up there. And with the greatest respect to my acute colleagues up here, quite a few of them, elderly people, will go into a strange place, get confused at night because they can't sleep, fall over on the nice slippy floors, break their hips, pick up those lovely bugs that we have lovely letters for MRSA. Many of these people should never have been in there in the first place. So my huge interest is keeping as many of them out as possible. And I think that by doing things differently in the community, we can manage that, but not without some extra resources. So I would agree with the questioner. We need some extra resources in the community to achieve this. So by having fewer people in the hospital, we will be able to transfer some of those resources to beef up what we can do in the community and reinstate those services that she has mentioned that are decreasing at the moment.
Thank you. So we need to pick up the points.
The next question that I picked up, the invitation for Stephen Eames to travel via blue light to Carlisle from Whitehaven. I'm not sure he'd want to do that, but he is able to. He is able to deal with the question that's been raised, I think, about risk again.
Yeah, I mean, just on the specific, I mean, I'm quite happy to take up that challenge. Funnily enough, we had a conversation with colleagues from the Overview and Scrutiny Committee last week who've got responsibilities to, scrutinise these proposals, and we are talking to them about that very thing, about going with an ambulance that's in an emergency situation to get the direct experience. So I think it's actually a really good point, and I'd hope we'd be able to feed some of that back as part of this process. And I would be perfectly happy moving on to the specific, I suppose, the underlying context of your point. But
can we allow
of course the patient there are patient considerations, but that's one way of responding to the point that you were making. But the underlying point, I think, is about safety and risk. And I come back to what I've said already, so I won't repeat it, but perhaps to use the example, a very specific example, back to the changes that were made in 2013, you might argue that puts some extra pressure on the ambulance service, but what we clearly know from making those changes, and that's about transport across those 40 miles for people with acute and serious surgical conditions, we have saved lives. And there's clearly a balance between access for people visiting those patients when that happens, but we're saving lives. And of course, the way in which we plan to use West Cumberland Hospital in the future, in any event, is to provide as much follow-up care for those patients as we do today and more locally at the West Cumberland Hospital.
I'd just like to ask Matt, as the representative of the North West Ambulance Service, if he has any comments on that.
Yeah, one point, David, I'd like to mention is that this the dedicated ambulance vehicle that we're talking about is ring-fenced purely for transfers. So the idea that you go up to Carlisle and you get caught in Carlisle just won't happen for that vehicle. It's purely for the transfers. So as soon as it's clear at Carlisle, it's straight back and ready for the next transfer, should there be one. Yeah, that's exactly what it's there for. Yeah, the only caveats to that at the moment, as the SOPs stand, and they're still being formed as sort of at the moment, but the only caveats to that are if there are maternity incidents in the community, which the dedicated vehicle would be better placed to attend than one of our other ambulances, then it could go for those, but purely for the maternity incidents. But otherwise, yes, it stays at West Cumberland, and what we're looking at is integrating the staff that are staffing that ambulance into some of the wards, so they get more experience both in the maternity wards, in ED and so on, whilst they're not being used for the transfers.
Thank you. There was a question about the incidences where we get a severe case that happens very quickly. I think Anna could best respond to that.
I think I responded to it earlier, and I acknowledge your concerns as a midwife. But I think as a midwife working in a midwifery-led unit, you would be risk assessing that woman when she came in immediately and continue to do so right the way through the intrapartum care. If you had heard a fetal heart dipping when you're using your Sonicade, you would make plans to transfer that woman straight away, and the dedicated ambulance would be there to support you with the paramedic, and you as a midwife would go with that woman to support that transfer.
Thank you. Hang on just a second. As a point of order, I made it very clear that this is a public record, so everyone's shouting out questions from the audience. Maybe very, very great questions, I'm sure they are, but we didn't catch any of them, and it's unfair to ask the panel to respond. So if you could wait until we get the...
So I could hear you were asking about the resources question from a midwifery point of view. Obviously, if we did move to the option where there was just a sole midwifery-led unit, we would be looking at a completely different staffing system to what we have now, with midwives being allocated on duty, but also having the backup of midwives coming in to support. So we wouldn't delay the woman transferring down to Carlisle. We would set that transfer off straight away, and we would call in one of our community colleagues to support on the midwifery-led unit in the meantime.
And I think it's worth just mentioning that whatever the decisions, in line with the process that Peter Rooney described earlier, it'll take some time to implement those decisions. So no one should imagine that overnight everything should change. It needs to be very, very carefully planned, and there'll be break points in the planning process where people will be asked to be assured that we're ready to move to the next stage and the next stage before the service, whatever it is finally up and running. That's a really important part of the thinking that we will need to go through after consultation so we can make sure that the plans are being implemented.
Thank you. Take the next set of questions. We'll start that lady there, then we'll come to here.
I think any woman that's in this audience...
Sorry, could you...
Yeah. Any woman in this audience and anybody who has contact with women who have delivered knows that any low-risk woman can at any stage develop a sudden hemorrhage, sudden problem that needs immediate attention. And it doesn't matter how far away you're from the consultant units, 30 minutes is too long. You want somebody there immediately. But my other point that I would like to raise is I cannot understand how the people in charge of our health services in this area are proposing these changes and transfers to Carlisle when we have such horrific roads. I think the first thing we would need to do is speak up in front with the government and make sure we get better roads before we make any changes at all. We have had a number of reviews over the last 10 years, and nobody has actually made any decisive recommendations because nobody dares to, because they know how bad the roads up here are. So, you know, while the system is so bad, we need the 24-hour cover for maternity at Whitehaven.
Okay, thank you. The red jacket there, please.
A lot of star during this process has been put on the failure to recruit staff. What is the regime and the trust doing about recruitment? We live in one of the most beautiful parts of the country. We've got some excellent skills and wonderful things to do for an excellent work-life balance. Are you listening, sir, please? No?
Yes, sorry.
On a quick search tonight before I came out this evening, I could find 13 consultant jobs at the Cumberland Infirmary and only one advertised for the West Cumberland Hospital. So why is all the recruitment going to the Cumberland Infirmary and none being recruited for the West?
Okay, thank you. Thank you. And we will return to this lady who's been waiting very patiently at the front here.
I think my question has been asked, actually. That's what I want to ask as well. If a low-risk lady is at Whitehaven at the midwifery-led unit and needs, for whatever reason, an immediate section, what's going to happen then?
Okay, thank you very much. So, Anna, would you, well, Stephen, do you want to...
So I think I alluded earlier to the skills that our midwives have and the training that they undergo to manage situations. You talked about, I think there was a lady over there asked the question about hemorrhages. That is one of the skills drills that we do all the time as midwives on how to deal with hemorrhages. And it would be, the process in this case would be to stabilise and then transfer the woman to Carlisle. The issue that you've just raised again about the caesarean section, I think I've answered that earlier in the evening. We would not be able to do an emergency caesarean section at Whitehaven because there isn't a consultant there under option 1, and as a midwife you would be at the earliest opportunity identifying that there was a problem in that labour and transferring to Carlisle.
I think the question, just because I'm sensing the audience isn't quite satisfied with that answer. So in a situation where unforeseen there's a demand for an emergency caesarean, what would the response be then? I think that's the question. I understand.
We would have to transfer to Carlisle.
Okay, thank you for that. Yeah. So
just thinking that Anna's made, I think, a very clear response from a professional midwifery point of view, but it might be helpful for Rod Harpin to say a little bit about the issue that's come up 2 or 3 times. Rod, do you want to pick that up?
I think one of the dilemmas, and I think it's reasonable to say one of the dilemmas is this issue of the emergency caesarean section, and Anna's tried to answer it, and I think is trying to indicate that the women in a midwifery-led unit are being monitored from the point of view of whether they are getting into a situation, whether they would need that emergency caesarean. It is a change in practice, and the idea is to get the woman to a point where she didn't need that emergency caesarean section. Now, the national birthplace evidence from the birthplace study is that the issue of needing to transfer in an emergency is very, very low. And it can happen. The idea is to risk mitigate and avoid that happening. So, in essence, I will...
Please allow the speaker to finish.
Yeah, I will complete the answer, and that is that the evidence for most of the transfers in labour from a midwifery-led unit to a consultant-led unit is actually for pain relief and not for emergency reasons. And certainly the midwifery-led units that are freestanding in this country are safe and they are functioning. The distances, well, I think we will feedback from the distances and the evidence from the South Wales model. Yeah, well, the distances are similar, and I think we will feed that back onto the website.
So just as a point of order, it's very important to say that as a consultation process, it's clear that you need to express your concerns. Our job is to make sure those concerns are recorded and that panel responds, and it is fed into the process. And I think what we need to do, I understand it's a very, very emotional subject, and if I lived here, I would feel the same way, is allow the speakers to finish, if you wouldn't mind, and I'm going to throw back to the panel to continue with those answers.
I just wanted to... I mean, this is such a fundamentally important issue, and no one could deny that. We absolutely understand that. But the overall issue of risk between that risk which you're describing versus the risk of doing nothing is the kind of spectrum of risk that we need to consider very carefully. And Stephen Singleton, I wonder if you want to comment on that and any other aspects of this.
Well, I want to emphasise the point about how interconnected all of this is, and that people are absolutely right. And we've been hearing this since before the public consultation started. It was part of the engagement process. It was part of the Royal College of Obstetricians review. It goes back even further than that we are struggling with hazards in pregnancy. There are hazards. And the way we deal with some of those hazards at the moment is 2 relatively small units. There's another 2 in the south part of Cumbria, if you count Lancaster and Barrow. So we've got 4 small units. And when these hazards happen, and many of them are really quite rare, but you know, we want to be able to cope with them when they happen, we get to the stage, for example, in advanced labour, where things get to need to have to do a caesarean section. And we offer that at the moment in 2 different places. And we offer that as part of the deal that we have with you about what services should look like and how they're configured. And as Anna was trying to explain, if you've got a consultant service, labour advances in a way which leads to some of them ending up with emergency caesarean sections, but we planned for that. The problem with the current leave it doing nothing, so we've got these hazards that we try and mitigate all of the time with the way we do it. The problem that we've been facing is as simple as this. That deal that we have with you, that we'll have 2 small units able to do pretty much most of everything, and they help each other, and they're helped by Newcastle for very rare cases where things can only be solved in Newcastle. That deal assumes that when things go wrong, we've also got a paediatrician. We've also got an anaesthetist. We've also got everything else available. And at the end of the day, we manage that at the moment with an eye to the fact that the regulator comes along and says, I'm not sure that this is exactly right doing it like this. You need to look at it again. We do a review with the Royal College. The Royal College says, I can see because of the distances, because of all the arguments you're using that we know too, and that we agonise about too, and that we lose sleep about too. We know all of those arguments, so try and do it with the 2 small units. Try. And that's what we've been doing the last 18 months. And, you know, I'm sorry if I came across as rambling earlier. It's not rambling, it's how complicated and difficult it is to get all of those bits of the jigsaw in place all of the time so that we maintain our deal with you as a community that service will be there. But actually, if all the paediatricians are locums, if the obstetricians in the middle of the night, who are also middle grades, are also locums, if the anaesthetist is down in the A&E department dealing with something else, we, CQC, everybody else says, hang on a minute, this isn't the deal you've got with the community, that all comers can come here and we can cope with everything. Now, many of you will know that during the process of talking about can we do that, can we sustain that, we'd like to keep going with that if we could. Can we keep doing that? During that conversation, the local obstetricians has said, well, actually, if we can't do that, we want everything in Carlisle. So option 3 was what they said at one stage. If we can't manage all the bits of the jigsaw all of the time, let's have option 3. And we said, but hang on a minute. Actually, all over the world, people manage, for some pregnancies, midwife-led unit. And that would be an important choice for people who've maybe had a couple of babies already. Their pregnancies have gone well. They're expecting the labour to go smoothly. They know what they feel like, and so on and so forth. Why can't we have that choice? And ultimately, that was why it's our preferred option. And we expect all of these discussions. We expect all of these arguments because we've been through them ourselves endlessly to try and work out what is the best way of mitigating this risk. And it comes back to this recruitment. So what are we trying to do? You know, I've been, over the last year, to every forum I can think of trying to recruit GPs into the area. We go to every recruitment fair that we can think of, whether in London or Newcastle. We advertise all of the time. And, you know, the way the adverts come across, just because somebody says this is a Cumberland Infirmary job or a West Cumberland Hospital, this is a job to make services safe here in Cumbria. And they work as a team across the 2 sites sometimes. And you can't always tell from the advert what the person's going to be working with. I have a colleague who's just come back from India, trying to recruit paediatricians from India. I was in Liverpool only last week, talking to medical leaders from all over the country. How can we get more people to come to Cumbria? How can we get those bits of the jigsaw into place? We're doing that all of the time, and still the risk is there that those hazards can't be met by 2 small units struggling on separately. We have to find a way of attracting people, because you know what people say to me? Be they a paediatrician, anaesthetist, an obstetrician, they say, a unit that delivers only 1,300 a year? Actually, I'll stay in Newcastle. You know, a unit where I'm going to be on call once a week and frequently at weekends, I'll stay in Newcastle. The young people who we want to attract here are looking for evidence that we're thinking not just about next month or next year and keeping our fingers crossed that the locums keep turning up. They're thinking about a 20-year career and what's our ambition for how we could do it differently and specially. And, you know, we've talked to some of the midwives, some of the people in maternity liaison and so on. We could have a different sort of service here in West Cumbria, a service which other people are jealous of because we've built something which is different and special and okay. It depends upon a network with Carlisle. It depends upon how we manage these risks. But if we don't do anything differently, if we don't think about the next 20 years as well as about the next 20 minutes, then the young professional people won't come. And if they don't come, the GPs won't come. And if the GPs won't come, where will we end? Now, I've struggled with these things for 20 years. I am not minded to just cross my fingers and hope for the best. I am minded to consider difficult options, and are these difficult options actually better than staying with things as they are? Now, of course, we don't want a disaster in the back of an ambulance on the road which is flooded because it's rained a lot that night or it's snowing. Of course we don't. But we don't want to deal with the community that we have to come back to next year and say, well, we thought we could do that, but it turns out we can't. We want to find the right way forward. And that, by the way, and I'm sorry I didn't emphasize it, this is my final point, I'm sorry I didn't emphasize it. That's why option one isn't quite the same as status quo. We have to find a way of getting the unit in West Cumberland Hospital and the unit in Carlisle to work as a single team, a single network with the unit in Newcastle for the safety of everybody.
Thanks, Stephen. There was a question about
specific recruitment.
Specifically about recruitment.
Yes.
Stephen has alluded to that, but
Yes.
Stephen Eames might
I think so.
I'll be brief. On your question, wasn't it, about what you had seen on the website? Can I make it really clear that there is no intention at all to differentiate recruitment between both ends? And actually, we've got a more challenging recruitment problem, as you probably know, at the West Cumberland Hospital than we do in Carlisle. The best way to answer your question is to set out very clearly, which we can on the website and in other ways as a response to your question, exactly what we are doing. But I can assure you, I'd be failing personally in my job if we weren't making sure we were trying to recruit. There's been lots of efforts. The other thing I would say that we've gone beyond the normal recruitment process. We have what we call a 10-point plan. I won't go through all 10 points, but for example, we're paying extra in shortage specialties. We're looking to support people to bring their families if they want to work here. In West Cumberland specifically, we're working with Michael Starkey, the mayor, because this is a problem in every walk of life in our part of the world. And like you say, it is a beautiful place, but we're working collectively to try and recruit. And Sir Neil made the point much earlier on, and this I think is one of the keys to success, is we are designing new roles for nurses and people who want to work in the medical world but have not gone through the traditional path. It's already happening, and it's happening at West Cumberland. And in that example, I can tell you, I've been here for a year. From next February, we'll have 23 people working as physician associates in training in West Cumberland. Today, we've got 28 nurses with extended responsibilities working in West Cumberland. We expect to double that in the next year or so. So we are really trying. But rather than me go through it all, let's put that evidence out there so you can see it. It's a very, very important question.
Okay. Thank you very much. Right, I'm going to take 3 more questions.
So there was a question about transport that the lady raised here, and there are details on our website about our proposals for transport beyond ambulance service transport. Your point about the roads is a good one. We have talked to MPs about the state of roads and the requirement for investment. I'm sure the CCG has done similarly over the time. It seems to me that this ought to be an issue where the local people constantly remind the politicians of the need to improve that aspect of transport. It requires attention. There's little doubt about that in my view.
Thank you. Right, the lady there has been waiting.
Thank you. My name is Evelyn Bitcon. I'm a Workington girl born and bred, and some of the panel will realise that I've actually attended quite a few of these meetings. I have a genuine interest in improving the lot for people in Cumbria, especially the vulnerable and the disenfranchised, who I actually advocate for. And by coming to these meetings, I'm looking for this openness, this honesty, this transparency, this listening, this hearing. And I'm afraid, yet again, what I'm seeing is a very defensive, guarded take on to defend those options that you've gone with, that maybe you're going to learn that your consultation is flawed, because there are people out there like me that believe it is. If you look at the criticisms that have come into Cumbria to the CCG from NHS England, and severe criticisms, which people should hold their hand up to, and if you look at the regulators' criticisms that's come into Cumbria, these are not faults of the public. These are not faults of the patients, the carers who never get a mention, and I'm talking about the family carers here, because we have a very poor supply of the paid carers, so your future plans are going to really hit a brick wall. I look at this consultation now and I think what you've done, you've looked at the clinical and the medical side of it. You've certainly looked at the political side of it, because we know things are happening across the country, especially like midwife-led units. And I have every empathy what these people have actually said in here tonight, but I just wonder if they're being heard, genuinely being heard. If you look at the humanitarian model, which is what I believe in...
I don't want to shut you down, but we're running to the end, and I'd like to bring more people in. Okay.
Thank you.
I just want to give people a chance to speak.
If you look, I'm actually speaking for everybody in this room right now. If you look at humanity versus politics, right, what you will see in this county is we have a higher than national average of suicides, we have a higher than national average of elderly, and by 2020, 25% of our population are going to be elderly. Services are being cut right, left and centre. We have a higher than national average of poverty and deprivation and long-term conditions. We have a county that's got geographical rurality issues with very poor road networks. And we've also, looking at the recruitment, and having worked in the NHS and social services in the third sector over many years, I've heard all this. We can't recruit into Cumbria. We can't recruit into Cumbria because people don't come to where they can't further their careers. And again, that is not a public problem. That is a strategic management leadership problem. That has been criticised by NHS England. And what I need to say here is, instead of the defensive, we have to change because we can't recruit. Let's change the strategy of management in Cumbria. We can't afford all these boards of directors. We need one health, social care and wellbeing board in Cumbria to save some money to treat the people when they need it. Because a lot of money is going out on boards, which we can't afford. And I just need to ask this, because this is historical. Our problems and our issues are historical. And for transparency, I would like to ask the questions that have there been blocks on recruitment over the last 10 years in Cumbria? Because I have knowledge that there have been. So that's another reason why we can't recruit. And especially people coming out of our local university looking for jobs. And have we actually looked at the last closer to home consultation as a lessons learnt example before this was put together, which I very much doubt? And the other one I want to ask is, what is the name of the independent body that is going to be putting all this together at the end, please? Because for God's sake, don't let it be ex-NHS professionals who have set up in consultancies. Thank you.
Thank you. I think you've raised a lot of very important points. The audience clearly is supporting you, so I'm not going to take any more questions at the moment and allow the panel to respond to those well-made points.
Really important points, and I want to do my best to deal with them. You argue that we're guilty of being too defensive. We have done our best to describe the dilemmas that we believe the health service in West, North and East Cumbria faces. and we've done our best to describe our views about how change needs to happen, because remaining with the status quo carries too many risks in the medium to longer term. If we haven't explained ourselves well enough, then we should think again and do better in terms of the remaining part of the consultation process. You argue that the flaws in the system as identified by regulators are not the fault of the public, and we would never ever say, nor have we said, that it is the fault of the public, but they exist. Some of them are not the fault of mismanagement. In fact, I don't think any of them are the fault of mismanagement. There are a whole variety of reasons which Stephen Singleton and others have attempted to describe about why we find ourselves, why we are. But then that's another reason exactly why we think these kind of changes are necessary. You make points about humanity versus politics, I think is the way you describe it. We make reference in the document to the need to plan for a changing age profile within the population. That's one of the reasons why integrated care communities is such an important part of our proposals. We make the point that the health of the population is not as good as it ought to be, and there needs to be a concerted effort by the CCG, by the health partners, and also the local authority to do more and more about how to improve health and to tackle the problems of deprivation. You raise a point, you raise many points. The next point that you raise, which strikes a chord with me, is the importance of thinking about how to manage services in West, North and East Cumbria differently. And we haven't talked about that. It doesn't even feature on one of our slides, but there's something, I think, in the consultation document. We're looking at this very carefully indeed. We absolutely recognise that the way in which the NHS in this part of the country is organised, and social care, the local authority agrees with us as well, is not the best way to deliver a properly reformed, modernised, integrated health and social care service for the future. So we are having active discussions about that as we speak. In terms of recruitment, I'm not sure there's much else we can say about that, but Stephen Eames, I know, would be happy to add to the comments he made earlier. The independent body who Peter Rooney alluded to earlier is the Consultation Institute. It is an entirely independent body which scrutinises and supports consultation exercises, gives advice about them up and down the country, and they will be the arbiters in terms of the comments that you give and we receive, whether or not they've been well balanced in terms of our responses to them. So that is as independent, I think, as it possibly can be. I suspect I've not done justice to all of the points that you've raised, but I've done my best to answer them as best I can. If there are other points that you want to talk about, we talk occasionally. I'd be very happy to deal with the other issues that you might have on your mind outside of the meeting, if that helps.
Thanks very much. We are due to finish at 8:30, but I'm very conscious that there's still a lot of people waiting to ask questions. So I'm going to prevail on a panel to stay a bit longer, and I'm going to take some more questions. So, lady here has been waiting for quite some time.
Thank you. This is about the consultation process, just a question about that. Do we think that enough has been done to raise awareness of the public consultation booklet and the actual process that's going on? Because a lot of people that I've spoke to don't even know it's occurring or any information whatsoever. When my husband before alluded to the fact that there's not that much information given on each of the options, because we found out tonight, obviously, that crash C-sections wouldn't be happening at West Cumberland Hospital. I didn't know that beforehand. A lot of people do not know that beforehand. And different things like that. If you're going to feed back some and make some more transparency on these issues, will there be a further booklet with all these information on, some sort of information going forward to outline exactly what the options are?
Thank you. Behind there.
Just the same as the lady, really. The consultation process is to be able to, for us all to make an informed decision. So to enable us to do this, I want to know, will we get to see these risk assessments before the end of the consultation process?
Okay, thank you. Any more questions? Well, yeah, and I'll come back to those in a minute. Let's just take these.
Theresa May came out and said last week that she wasn't going to support any decision made about healthcare in Cumbria. So how would the panel respond to Jamie Reid MP's comment? He said that the consultation was a very expensive paper exercise and the decision had already been made.
Thank you. So questions essentially about the consultation process. So I'll ask the panel to comment.
Let me see if I can, I'll ask Stephen Singleton to make a comment again about risk assessments. The dissemination of information is something we talk about regularly. We thought about it well in advance. If there are people in this audience who have ideas about how we might do that better, then we'd be very receptive and very prepared to listen to that. We have a website which includes all of the documents we've published over the last year or so. It includes a very, very lengthy and some might argue technical document called the pre-consultation business case, but within there are lots of pieces of information about financial assessment, about activity flows of patients, about risk assessment, and we publish a lot of fact sheets, information sheets that also feature on the website. There's one on maternity services, for example. There's one on transport that I alluded to earlier, and I think there are about 20 others as well. Now, if they're not giving you the information that you feel you need to make an informed decision, then please tell us, and we'll do our level best to try to rectify that. The Prime Minister's letter made it clear that there was a process underway called consultation. And she made it clear that she wanted to see the consultation process proceed and leave it to local people to see if they could come up between them with decisions that ought to make services better. And if Jamie Reid is saying decisions have been made, then frankly, he's wrong. And I'm very happy to tell him he's wrong when I see him in the near future.
Thank you.
The answer is yes. We've had a lot of requests to put our process into a clearer form so that people can understand how the risk assessment is happening. So before the end of the consultation, there will be more information, as Neil says. For example, the maternity one, the fact sheet's just been updated, and only today I got sent some more information by a retired consultant to add to the risk assessment process. He's going to come in and talk to us about what his interpretation is and so on. So the process is ongoing, and we will make sure that you can see our thinking as transparently as possible.
Just to sort of, you were saying, any ideas to sort of get it out there in the public and get more opinions and things like that. This is a leaflet that I've received through the post on the Moor side. It's a consultation process open from the 28th of October to January next year. And it shows, can't really show from here, you're quite welcome to have a look. All the area, all the information, it shows exactly what they're going to do, what the options are. We've had nothing through the post or nothing. The only thing that I found was on Facebook or on your website because I already knew about it. If I didn't know about it, there's nothing that's come through the post to local people who don't have access to the internet or are not on Facebook or anything like that. So I'm just concerned about those 8 people. Because was it Peter yourself at the front, saying that everybody should be, the public should all be behind it and having all their opinions, but do people know about it?
Thank you very much. Point really well made. And I would urge you to talk to the panel before they leave and to share your points. We've got some questions over there. There's a gentleman up there.
Hi. Mr. Dayburn, I think it was, mentioned from the Welsh thing that you're going to look at this week, that they use helicopters. Has that been considered in this context, in this area?
Okay, thank you. Any more questions?
There is already a landing pad at the West Cumberland.
Okay, thank you. Any more questions? Lady there hasn't spoken.
Thank you. I sometimes think that people like you on the panel think you're between a rock and a hard place, but I think it's the people of West Cumbria who are between the rock and the hard place just now. I want to ask you about something you said on your slides, which hasn't been that clear. You have an overspend, I understand, of £80 million, rising in 4 years' time to 163. And you reckon that all your the work you're doing will save £132 million, which leaves a financial gap of £30 million approximately. So I'd like to know what you're going to do next to close that gap, because I feel another consultation coming on about something else.
Okay, thank you. I'll take one question here, and then we'll shoot to the back, and then we'll call it there.
I just want to know how Carlisle did with the CQC, because you keep saying that West Cumberland did really, really bad. Well, as far as I know, that Carlisle didn't do very well either. And there was a bit of a crisis last winter at A&E with ambulances waiting outside and not enough beds. I'm talking about my mum who had emergency surgery and ended up on a day ward because there was no emergency beds. Why does everything have to be at Carlisle? Is it because Carlisle were in deficit before they even opened the doors, and bring all the services back to West Cumberland?
Okay, thank you. I'm going to take the last question at the back and then allow the panel to respond. And what I would urge you to do in the meantime is, if you feel you haven't been answered, please wait behind and talk to the panel and look at the other ways you can be engaged in the consultation, which are in the booklet. But I'll take your question.
I am concerned for people, you're talking about Carlisle being more the centre for people that are seriously ill, and obviously for the children, if there isn't going to be an overnight ward in West Cumberland. Children that have either chronic illnesses or disabilities can often find themselves in and out of hospital all the time. If that's going to be Carlisle, and I understand you're saying because there'll be the expertise there, have we given consideration to the impact of this on families, for families that are already stress dealing? And I'm not just talking about children, I'm talking about adults, perhaps with chronic disabilities, serious illnesses that are in and out of hospital. For people living Whitehaven, Egremont, whereas some people have cars, what about people that don't have cars? We've not got an adequate transport system, or if you actually want to finance it from getting from your house to the train station, to Carlisle, for a taxi or bus or whatever to a hospital, the cost of it, the time of it, to people that are perhaps in very, very stressful circumstances. So we've got to look at the experience of patients and the experiences of families at perhaps one of the worst times in their lives.
Okay, thank you. Okay.
If I kick off, and if I can come to the question about the Care Quality Commission, you're absolutely right. The Care Quality Commission's assessment was about the whole trust. It wasn't just about West Cumberland. There was a very specific set of concerns about West Cumberland to do with some of the fragility of the services through recruitment, the sort of thing that we've been talking about this evening. What the Care Quality Commission was saying to us, as your regulator actually, in that sense the defenders of the public in terms of quality, is the way that you're organised currently with two small hospitals means that it's going to be very, very difficult to maintain the sort of national standards we have to work to. Now, we've been working very hard on that, and I would say that despite some of the challenges and serious issues that we've talked about this evening, we do have a very clear strategy that we're setting out here, however the balance of options comes through on the consultation. And I would add that the Care Quality Commission are actually revisiting in a few days' time, actually, in about 15 working days' time, to assess the progress that we've made against their concerns. I'm confident that we have made quite a lot of progress despite the challenges, but we'll wait and see. That report will be published in the new year. But you're absolutely right. This isn't just about West. This is about the whole service. The other part, I think, of the question was this issue about the pressure on emergency services. And again, you're absolutely right about that. I should just say, and I can only speak about my time here, that the Trust currently is hitting its agreed targets on emergency care. We're not doing enough, we need to do more, but we're doing better than we were. That's encouraging, but the fundamental way in which we'll deal with that issue is related to what Neil was saying earlier on, our GP colleague in the front row, that it sounds a bizarre thing to say, but actually if we had the sort of infrastructure in place in the community alongside people in their homes and in their local setting around the community hospitals and so on, we've actually got too many acute beds, because something like 25%, sometimes on Sundays 30% of the people in our beds are actually well as far as the acute phase of their care is concerned. And then the other point I would make, which I think comes out of what you were saying and what someone else was saying, you're absolutely right also when people are talking about long-term conditions and the demands. I mean, that's a huge part of the pressure on the National Health Service everywhere, but particularly here because of some of the reasons that colleagues have explained. And that's why it's so critical that we're able to provide, alongside the proposals we're making around hospitals, services that mean those people don't have to come to hospital at all. And that's what the integrated care community model's about. You know, if you've got cancer, if you've got you know, a really difficult diabetes problem, if you've had a stroke, the best place for you is at home with your family with the appropriate medical and nursing support. And we're all massively committed to delivering all of that. So I hope that gives you some sense of where we're trying to get to with our proposals. Oh, sorry, and the point, sorry, can I just deal with the telemedicine question? That's an important point, especially for our area. We've done a lot of work on that. Where we've settled, and I don't know, this is very recent, so it may well not be out there fully, is we have recently agreed to make 2 appointments of accident and emergency consultants based at West Cumberland, I just emphasise that, based at West Cumberland Hospital, who will spend half of their time in the working week paid working for the air ambulance service, the North East Air Ambulance Service. Now that gives the air ambulance service extra capacity. So we are making investments, and that's the most practical way we think to move forward. And without boring with all the details, we've had a lot of expert opinion from clinical colleagues working in the air ambulance service in Scotland, and who's also got a national perspective, and that's what's come out of that. We're actively recruiting to those posts at the moment, and I can tell you we've already got some very good candidates, so I'm very optimistic about making those appointments.
If we could pick up the question about the funding.
I just wanted to make a very brief response. The slide doesn't show the whole picture. If you look at the pre-consultation business case, the document I alluded to earlier, it has all of the detail you will want to see. Let me just reassure you that the financial recovery plan we have produces balance. So there is no suggestion whatsoever that we've got a gap that we don't know how we're going to fill it, and therefore we need to come back and look again at further consultation proposals. That's not the intention at all. There is a balanced financial recovery plan. It's going to be very challenging, but we're confident it can be delivered.
Okay, thank you. And the last question?
The answer to your question about have we thought about the travel of families as well as the travel of the patients, be they children or otherwise, the answer is yes. All of the modelling is included, and one of the reasons, for example, with the sick children, for absolutely preferring to have acute assessment in 2 places is, as you will know, many children need assessment and maybe review the next day without being in a hospital bed. But if they are sick, they need all the bells and whistles as well. So there's not much in between. So we've firmly thought about that, and firmly thought about how we can make sure, as we were trying to describe earlier, as many things as possible are done as locally as possible, so that people only have to travel when it's essential.
Thank you very much. I know there are a lot more questions, and we could spend the rest of the night, but we genuinely have run out of time. It's down to me to thank you as the audience for the genuineness of your responses and the patience that you've shown in getting round to you. I really appreciate it. Very honest questions. I'd also like to thank the panel for their contributions. And I know they're not leaving immediately if you have other questions. I'd also like to say that there are still copies of the consultation documents. If you have not seen them, I would urge you to have a look at that, because not only does it give you the summary of the options, it also directs you to where all the detailed options are contained, and it allows those people who have had not the chance to speak this evening the opportunity. It shows how you can contribute in other ways to this consultation, and I would urge you to, if you feel your voice hasn't been heard so far. So thank you very much, and thank you to the panel. Good night.